I'll be talking about the management of Cushing's disease. So, as you can see in the cartoon, Cushing's disease presents with emotional disturbances, enlarged erotica, moon phases, osteoporosis, cardiac hypertrophy, buffalo hump, obesity, adrenal tumor or hyperplasia, thin wrinkled skin, abdominal purple striae, amenorrhea, muscular weakness, especially proximal myopathy, purpura, skin ulcers with poor wound healing. So, coming to the background, in 1932, Harvey Cushing described a syndrome characterized by serious manifestations consequent to systemic effects of chronic exposure to cortisol, which has been found at autopsy in 6 out of 8 to be associated with a pituitary adenoma. Corticotroph adenomas represent 8 to 10% of all the surgically treated pituitary adenomas. They are more common in females with a ratio of 3:1 to 10:1 in various studies, most common in 3rd to 5th decade of life, and they are the most common cause of non-iatrogenic Cushing syndrome. The most common cause of Cushing syndrome is iatrogenic Cushing syndrome, and in the non-iatrogenic causes, the most common cause is the pituitary adenoma or Cushing's disease. So, normal hypophyseal pituitary and adrenal physiology is hypothalamus secretes the CRH, which acts on the anterior pituitary to secrete ACTH, which stimulates the adrenal cortex to release the cortisol, which has a negative feedback on both the anterior pituitary and the hypothalamus. So, this is the normal feedback which I just talked about, and here we can see that the cortisol will have a negative effect on both the hypothalamus as well as the pituitary. Now, what happens in Cushing disease is that the normal negative feedback doesn't work that much. So, we have increased ACTH level because of the increased secretion from pituitary adenoma. If we talk about adrenal lesions such as adrenal adenoma, adrenal carcinoma, or nodular dysplasia of the adrenal gland, then we have increased cortisol, and that has a negative feedback on the hypothalamus and the pituitary, and that leads to decreased ACTH. Now, the third source of Cushing's syndrome, non-iatrogenic, is the ectopic ACTH syndrome, in which there is very much elevated ACTH, and that leads to increased cortisol and doesn't much have a negative feedback because there is autonomous secretion from a non-pituitary, non-adrenocortical neoplasm. So, as we can see from this, maximum ACTH would be in ectopic ACTH syndrome. After that, we'll have Cushing's disease, in which ACTH is elevated, and in an adrenal disease, the ACTH is decreased. Clinical features I have already talked about. Now, the etiology, we have the ACTH dependent Cushing syndrome, which can be due to pituitary lesions or which can be ectopic. Pituitary lesions form 85% of the cases, in which corticotroph adenoma is the most common. In rare cases, we have the carcinomas and the primary corticotroph hyperplasias. Ectopic ACTH lesions, we have the small cell carcinoma of lung. Other than that, we have carcinoid syndrome, islet cell tumors, medullary thyroid carcinoma, pheochromocytomas, and other rare tumors like ectopic CRH producing lesions. In the ACTH independent Cushing syndrome, which forms around 20% of the cases, we have the adrenal adenomas, carcinomas, nodular adrenal hyperplasia, and exogenous steroids. And there are also pseudo-Cushing states, which includes depression, alcoholism, obesity, diabetes, and PCOD. Now, coming to the diagnosis of Cushing's disease, the first thing is to establish hypercortisolism. The second thing is to find out what's the cause of the hypercortisolism, whether it is ACTH dependent or ACTH independent. If it is ACTH dependent, that means the source is either the pituitary or some ectopic ACTH secreting tumor. If it is ACTH independent, that indicates that the source is adrenal. And finally, if we find out that it's ACTH dependent, then we have to figure out whether it's due to Cushing's disease or whether it's due to ectopic ACTH excess. So we'll come to each step one by one. So to establish hypercortisolism, we have these three steps: first, second, and third. The first and the most common, the first choice of screening is the 24 hours urinary cortisol, which, if found to be more than 90 microgram per deciliter per 24 hours by radioimmunoassay, or more than 50 microgram per deciliter per 24 hours by immunochemilumiноmetric assay, is suggestive of hypercortisolism. The second test is a late night salivary cortisol, which, if found more than 0.13 microgram per deciliter or 3.6 nanomole per liter, is suggestive of hypercortisolism. And the sample for the late night salivary cortisol is between 11 p.m. to midnight. The third test is the overnight dexamethasone suppression test, in which 1 milligram of dexamethasone is given at around 11 pm, and the morning cortisol level, if found more than 1.8 microgram per deciliter, is suggestive of hypercortisolism. Let's also talk about the diurnal variation, which is normally present in the ACTH cycle as a part of the normal circadian rhythm. This diurnal variation is lost in Cushing's disease. Otherwise, in a normal individual, in the early morning, we have the maximum levels, which can range from 6.5 to 25.4 microgram per deciliter, and the minimum level is at the midnight, which is less than 3.6 microgram per deciliter. But this diurnal variation is lost in Cushing's disease, and it is always advisable to check for diurnal variation more than twice to be sure about it. And random collection of blood sample is not recommended in Cushing's disease, and we have to strictly adhere to the timelines. Now, once we have established hypercortisolism, the second step is to find out whether it is ACTH dependent or ACTH independent. For that, we have a simple test of plasma ACTH levels. As I had talked about in the previous slide, maximum ACTH is seen in ectopic ACTH secreting adenomas, such as the small cell carcinoma or the carcinoid tumors. That the range is more than 200 picogram per ml. For the corticotroph adenomas, which are seen in the pituitary gland, the ACTH level is normally 80 to 200 picogram per ml. And if the source is adrenal, the ACTH level is decreased. Now, coming to the last step, to how to differentiate between the Cushing disease and the ectopic ACTH. So for that, we will have 4 tests. The first thing is the cellular MRI, which is the best. We'll have the bilateral inferior petrosal sinus sampling. We'll have the high dose dexamethasone suppression test. And lastly, we'll have the CRH stimulation test. So coming to the cellular MRI, it has the highest level of accuracy for tumor localization with a positive predictive value of 86%. And 18% of patients have microadenomas that are not visible on MRI, and always dynamic MRI is recommended. Half dose contrast MRI scans or spoiled gradient recall or the SPGR acquisition is advisable. So this is a slide showing the importance of a dynamic MR in cases of pituitary microadenoma with Cushing's disease. As we can see in this Steven contrast weight images, the pituitary adenoma is not well visualized, but with the dynamic scan we can see a better localization of the pituitary adenoma as pointed by the arrow. Now coming to the inferior petrosal sinus sampling, we either administer desmopressin 10 microgram or the CRH 100 microgram. It's administered IV over 15 seconds, and sampling is executed from bilateral inferior petrosal sinus and peripheral vessels prior to and several times within the 10-minute period. If the value of inferior petrosal sinus to the peripheral smear is more than 2 before injection, it is suggestive of a pituitary adenoma. The ACTH value of inferior petrosal sinus and the ACTH value of peripheral smear blood. If it is more than 2 before injection, it is suggestive of Cushing's disease. If it is more than 3 after injection of desmopressin or CRH, it is again suggestive of Cushing's disease. Now we can even localize using the inferior petrosal sinus sampling, but it has a poor accuracy in terms of localization. For example, if the ACTH value of the left side divided by the ACTH value of the right side is more than 1.4, it is suggestive of a left-sided pituitary adenoma, and vice versa. Now coming to the high dose dexamethasone suppression test. So it's always advisable to give a single dose of 8 mg rather than 2 mg 6 hourly. And if there is a 50% reduction in urinary or plasma cortisol or serum cortisol level is less than 5 microgram per deciliter, it is suggestive of Cushing's disease. And the last test to differentiate these two is the CRH stimulation test. So CRH is given 100 microgram IV, and within 30 minutes we find 50% increase in ACTH level and 20% increase in plasma cortisol level, which is suggestive of Cushing's disease. Now, treatment of Cushing's disease is primary surgical, and the adenoma needs to be evacuated. And the second line therapy is the medical therapy or the radiation therapy. Finally, we have the bilateral adrenalectomy. In the radiation therapy, we have the conventional radiation as well as the stereotactic radiotherapy, such as gamma knife radiosurgery. So, when we talk about the surgery of pituitary adenoma in terms of Cushing's disease, the microadenomas can be very difficult to locate, and it's better to use neuronavigation or ultrasound to facilitate the finding of the adenoma. We should always have a wide exposure of the cella. The four blue lines of the anterior and the posterior intercavernous sinus and the two cavernous sinus should be well visualized. It is always advisable to avoid coagulating the dura, which can hamper identifying the adenoma, and the tissue color, texture and contour of gland needs to be identified. In case the adenoma is not well visualized, subtotal hypophysectomy can be done, and it is found to have remission in 70% of the cases. Cavernous sinus and posterior lobe always needs to be examined in the cases of Cushing's disease, because Cushing's disease location can be very variable. It can be inside the cavernous sinus, and it can even be supradiaphragmatic. So it is always advisable to look at the cavernous sinus, posterior lobe, to rule out missing of any of the adenoma, which can result in non-remission and recurrence of the disease. Now, coming to perioperative care, since the normal pituitary is under suppression, it is always normal to have a post-operative hypercortisolism, for which the patient needs replacement therapy from steroids for 6 to 24 months, and till the HPA excess is developed again. This therapy needs to be continued, and the normal maintenance dose is prednisolone for 5 mg in the morning and 2.5 mg in the evening as per the circadian rhythm. And supplementary glucocorticoid administration can be terminated if the morning cortisol level or stimulated cortisol level is more than 18, and if the patient doesn't have hypercortisolism or has eucortisolism or hypercortisolism, it is indicative of a surgical failure, because since the normal pituitary is under suppression, hypercortisolism in the postoperative period is the rule and not the exception. Now, how do we determine whether the HPA excess has recovered? So for that, we have the ACTH stimulation test as well as the insulin tolerance test, which is the gold standard, in which 0.1 units per kg of insulin is administered, and normal cortisol increment more than 6 and peak more than 20 is suggestive of a recovery of the HPA excess, and if it's less than 16, then replacement is needed. If it's 16 to 20, then steroid is needed only during stress. For the ACTH stimulation test, we use 250 microgram of ACTH, and if the peak cortisol is more than 18, an increment of more than 7, or peak more than 20, irrespective of the increment after 30 minutes, is suggestive of recovery of the HPA excess. Now, results of the surgery, we see that 60% of the macroadenoma gets cured, and 70 to 90% of the microadenoma gets cured. It's obvious, because the macroadenoma is more spread. They may have NOS4 presentation, they may be invasive, and they may invade the basal dura or the cavernous sinus, and hence their surgical excision may be very difficult. The recurrence rate is 10 to 20% at 10 years in microadenomas, and 12 to 45% in cases of macroadenomas. Now, when do we call the patient in remission or no remission? So if the morning serum cortisol is less than 2, it is suggestive of remission. If the urinary free cortisol is less than 20, it is also suggestive of remission. If the same values are more than 5 or more than 100, it is suggestive of a surgical failure and there is no remission. If the values are in between them, in the gray zone, like 2 to 5 of cortisol or 20 to 100 of urinary free cortisol, then it's a gray area and only follow-up is required. So favorable factors for resection of microadenomas is detection of microadenoma on MRI, no invasion in the basal dura or the cavernous sinus, histopathological confirmation, and low and sustained low cortisol post-operative. So there are many papers in which various amount of data can be seen. 54 out of 81 of our patients with Cushing's disease had remission following initial transsphenoidal surgery, 10 of whom relapsed later on. This is from other institute, this is from AIMS, and these are the various post-operative complications. As we all know, the major complications are permanent DI, post-operative CSF leak, bacterial meningitis, reoperation due to epistaxis, deadly carotid artery injuries, or permanent visual impairments. Now, failure of surgery, which can be due to many causes like invasive pituitary adenoma, large pituitary adenoma with cavernous sinus invasion, there are multiple options which can be done. There can be repeat surgery, or we can go on to second line therapy like medical therapy or radiation therapy, or the last resort of bilateral adrenalectomy. So medical therapy is only for the high risk post radiation and surgical failure cases. The various centrally acting drugs are paclitaxel, cabergoline, temozolomide, and the adrenal steroidogenous blockers like mitotane, ketoconazole, methylpropane, etomidate. There are experimental therapies like oscillodostat, levoketoconazole, EGFR blockers, CDK inhibitors, and R-roscovitin. Now, bilateral adrenalectomy is the last resort after multiple attempts of surgery, as an example for invasive tumor who are awaiting radiotherapeutic response and who are intolerant to medical therapy. Total bilateral adrenalectomy with gluco and mineralocorticoid supplementation is done. And we also have to talk about Nelson syndrome at this point, which is seen in 10 to 15% of the cases with bilateral adrenalectomy. They have aggressive and invasive adenomas, and they have massive increase in ACTH and MSH levels. Now, this is to summarize what I have talked about in the lecture. Go through these flowcharts, and this would be pretty obvious by now because we have talked about it in detail. And this is for the Cushing syndrome and etiology after establish ACTH dependence, independence, and then find the source and treat accordingly. And this is a similar protocol for the pediatric patients, which you can go through. There are also genetic analysis. Various genetic syndromes that need to be dealt with are the McCune-Albright syndrome, adrenocorticoid tumors, and the Carney's complex, etc. So that's all for Cushing's disease. Thank you.